Hi. Hi, this is Dr. Zeeshan Ghias from Gilgit, surrounded by mountains of Karakoram. I will be moderating last two speakers. So I would like to invite Dr. Shiraz Sayed for his presentation.
Okay, so today we're talking about a realignment case that I was fortunate enough to see with Dr. Shazib and Dr. Saeed at 1 o'clock at night, which is not very fortunate, but it was a very interesting case that we saw. So we thought that me and Aaron are going to present this today. So,
yeah, so going into the patient background, we dealt with a 49-year-old male who worked as a senior carer. His medical history was that he had hypertension, anal fissures, and also a right inguinal hernia. Additionally, he had social histories of cannabis use as well as prolonged alcohol consumption. His medication history also included antihypertensives like statins and also rivaroxaban for his DVT. So now if we look at the timeline of events, so in June 2023, the patient had found a lump in his right thigh. And after investigating, we found out that he had a femoral aneurysm on both his right thigh, and later we discovered that he also had it on his left thigh. We also found out that this patient had started rivaroxaban in October 2023 for the DVT. And this led to some complications, including MRSA infections at the obturated graft sites. So now moving into the clinical findings and also complications, he presented with symptoms of pain, numbness, and pulsating aneurysm on his right thigh. He also had complications such as the MRSA infection, weeping discharge, and massive bleeding.
so in this image, we can see that the graft has difficult access, being located in the obturator internus muscle. So when the images were reviewed, the question was, A, which approach to take, antegrade or retrograde, and secondly, the best method to keep the patient in during the whole intervention procedure. These are a few scans that we saw with the obturator graft feeding into a massive pseudoaneurysm. You can see the native popliteal artery with collateral branches given off. Post-imaging during the procedure, they injected via retrograde approach, and we saw a massive pseudoaneurysm just above the popliteal level. And what we saw distal to this is that we couldn't see anything related. So if you go to the next images here, this was the initial image, the second one we can see on the screen when the dye was actually injected. And we can just about see a faint outline of the obturator graft. Then a catheter was put in place to allow the opening of this arterial wall that was previously damaged. And then when the dye was initially last put in, we can see that there's now a new connection that was formed. Again, this is a CT 1 week post-procedure. We can see that the popliteal artery was accessed in the supine position due to the groin access restriction. The knee was flexed with a 5 French sheath used, and a trimmer wire and an angled catheter was used to cross the pseudoaneurysm at this stage. Now, the incidence of a graft anastomosis breakdown is actually quite common. Recurrent pseudoaneurysms at anastomosis sites usually occur 30 to 50% of patients, and it's more common in patients with underlying vasculitis conditions like Behçet's disease or complex surgeries like aortic arch repairs. And we also saw from numerous publications and even ourselves that there's a high risk of tissue repair in surgical repairs for these pseudoaneurysms. But in endovascular repair, there's usually it's less invasive with low incidence rates and quicker recovery. So the learning points to take away from this interesting case is that the angiogram should always be reviewed in different projections, AP, oblique, or LAO. Significant findings may only become evident in a specific projection, and it's always important to have correct access and visualization in these complex vascular cases to prevent any complications to develop.
Very interesting presentation. I would like to ask panelists if they have any questions.
I'm not in my house, but again, that was a pseudoaneurysm at the anastomostic site.
Yes.
So what is the recurrence of, again, pseudoaneurysm? There's a recurrence incidence at all?
Yeah.
Once treated?
If it's surgically treated, then there's a 30 to 50% ratio that we saw that does happen again. But with endovascular treatment, it usually typically lowers the rate. So it's less invasive and probably more safely.
So if there's a recurrence, then you will do surgical management?
Possibly, I'm not entirely sure with this, but I've heard that endovascular is typically preferred. However, if the pseudoaneurysm, I think, it develops complications, then maybe surgical option is preferred.
I'm aware of this case as well because I've been involved to some extent. So you can either get a lot of these patients either anastomotic or they're secondary to vessel trauma. So self-injecting, etc. Once you place the cover stent, you won't usually get a recurrence at that point. You may get a recurrence elsewhere along the graft, but not really at that point. As long as the graft is correctly sized. If it's undersized, then yes, you can get an ongoing leak of the pseudoaneurysm, in which case you need to reattempt stenting. We'll see that particular pseudoaneurysm will thrombosed up. And if there's no flow into that pseudoaneurysm, if you excluded the flow, then it will completely thrombosed up, regardless of etiology. But yes, you're right, they're still at risk. If they've got an underlying connective tissue disorder, they'll be at risk of developing pseudoaneurysm. That's right.
Thank you so much.
Thank you. Thank you.
So the last speaker of this fourth session is Benz Josiah. I would like to invite him on the stage and give his oral presentation.
Abdomen and pelvis.
Hi everyone, my name is Benz. I'm a doctor hoping to get into radiology like some of you here. I thought I'd present today an interesting case which I saw on a medical ward, which involved an occult ureteric rupture, which proved to be a diagnostic dilemma for the teams involved. The case was a 19-year-old female who presented to the A&E department with a 1-week history of productive cough, abdominal pain, and feeling generally unwell. She was treated as sepsis from a chest or urinary source. Unfortunately, during her time in the hospital, she was admitted to HDU for severe septic shock. She developed worsening abdominal pain, abdominal distension, a falling HB, and became increasingly hard to ventilate. The case was complex, involving general surgeons, gastroenterologists,
Contrast.
the critical care team, radiologists, and urologists in order to come to a diagnosis, which was a ureteric calculi causing ureteric rupture, leading to a urinary leak. The patient went on to have an abdominal drain, a nephrostomy, and a ureteric stent insertion for management. But how do we come to this diagnosis? Does the animation not work?
No, it's treated.
All right, so what you can't see behind these first 2 CT scans was the initial CT scan the patient had, which showed evidence of hepatic steatosis, ascites, and edema and inflammation of the ascending colon. The formal report also mentioned dilated left ureter, mildly, and inflammation of the left psoas muscle as well. When she was admitted to HDU, she began to develop this worsening abdominal distension with a fall in HB. So a repeat CT was done without contrast this time. And what you can see in this image is high density material within the abdomen, which pointed towards a possible bleed as a cause of this abdominal distension and pain. And in this image on the right, what you can see again is this high density material near the psoas muscle, and this was thought to be the source of the bleed. So the patient was taken to the angio suite for an angio of the mesenteric artery to look for a source of the bleed. What you can't see behind these pictures again is a clear angiogram with no evidence of leakage in any of the celiac axis, SMA, or the IMA branches. However, the team was still concerned with this abdominal distension and wanted to go and try again to look for a source of bleeding. The next CT abdomen showed increasing free fluid with high density material at the pelvic brim in the retroperitoneal space, which suggested there was a continued bleed. However, on further review of CT, what they found actually was a small ureteric stone in the left ureter. And the contrast that we see here was actually around the left ureter, which suggested that there was a rupture of that left ureter caused by the stone. And on re-review of the first CT she had in A&E, they found the stone again, which correlated with the proximal dilatation of the ureter at the time. So the patient went on to have a nephrostomy and an abdominal drain. And in this first image here, what we can see is a transection of the ureter just there, which would have caused the urinary leak. And this was confirmed with a nephrostogram showing contrast into the free fluid and not into the urinary bladder as you'd expect. This third image on the right shows the post-insertion of a ureteric stent. You can see some evidence of the contrast extravasation into the retroperitoneal space. But what you're seeing actually is successful insertion of the stent as contrast now goes into the bladder where it should be going in the first place. So, ureteric rupture in a nutshell. They're rare. They can be classed into two main groups, traumatic or non-traumatic, also known as spontaneous. In terms of non-traumatic causes, renal calculi is the most common cause, but other causes include connective tissue disease, retroperitoneal fibrosis, any compression of the renal system, so pelvic or abdominal masses. They can present, as was in this case, with a surgical abdomen, with worsening abdominal pain and distension. And in some cases, they can cause an abdominal compartment syndrome, which essentially is a persistently elevated intra-abdominal pressure of more than 20 millimeters of mercury, causing organ failure. And in this patient, she had an AKI and type 2 respiratory failure caused by oppression of the abdominal contents. The gold standard of imaging is to use a contrast-enhanced CT, looking particularly at the delayed phase images, because that's where you'll see contrast extravasation from the renal system, and it'll give you an idea of the size and location of the leak. And of course, if you're looking for a CT, if you're looking for a renal stone, non-contrast CT is the best imaging for that. So how does a urinary leak look like on a CT? Well, the most common presentation is a cystic mass in the perirenal space, which can be localized or diffuse. In this case, it actually was very diffuse, reaching into the from the retroperitoneum up into the abdomen. The treatment depends on whether the diagnosis is found immediately, so usually in surgery, or if it's delayed, like was in this case. And the European Association of Urologists had this guideline about how to treat management. So in this case, our patient had both a nephrostomy and a JJ stent. So in summary, I presented the case of a 19-year-old female who presented with signs of sepsis and required HDU admission. There was worsening abdominal distension and organ failure, but she was difficult to find out what was going on. When you see free fluid in the abdomen with signs of liver disease, you might think ascites. When you see, again, abdominal distension with falling HB, you might think there's an intra-abdominal bleed. This is what confounded the radiologist at the time, because there was a lot of factors that could have pointed towards a different diagnosis. Even the proximal ureter dilatation could have been caused by inflammation seen by that we'd seen in the ascending colon, which could have caused the dilatation. But what was nice to see about this case was the collaborative practice of radiologists. We know what radiologists do, but other people don't. And they think radiologists work in silos. So seeing the collaborative work of 3 consultants and a trainee come to the conclusion in this case was really refreshing to see. And of course, I want to be an interventional radiologist. So seeing the diagnosis and management of one patient case was really, really encouraging and makes me want to do IR even more. Thank you.
This was really interesting case, Dr. Benz. Now I would like to invite panelists to ask any questions, and at the end of the questions, Dr. Carlo will take over the session and conclude it. Thank you.
I just want to ask that what was the outcome in this specific patient?
We have question from Zoom panelists, please.
Other comorbidities for this patient. So she's still in hospital receiving treatment, but as far as I'm aware, the nephrostomy is intact. The stent is intact as well. So she's just been treated for other things now.
Thank you again for that interesting case. That's a very rare kind of case, actually. The point that I wanted to make really was, was there any in terms of the diagnosis, transection and partial transection in ureters makes quite a big difference in terms of how successful you might be with the ureteric stent. Because when you've got a full transection, trying to actually get a wire across is almost impossible. So the fact that you managed to get a wire across suggests that there's probably a partial transection in it. But it's amazing to see that even a partial transaction can make a patient so well.
So was initially when this patient came to the suspicion of possible uretile?
So
urinary symptoms related to the problem?
So she had recurrent UTIs. Dipstick was positive for a UTI. However, she was non-verbal, was unable to communicate very effectively. And so I think there was a lot of, assumptions made. The CT was done pretty early on because they weren't sure exactly what the cause was. But because of the history of recurrent UTIs, they went for a CT to look at, if there's any intra-abdominal pathology to cause, this symptoms.
So how long it took for us to reach the diagnosis? They were like serially IR.
So I believe it was over the course of 3 days. So that doesn't sound like a long time, but when you've got a patient who's come to A&E and then quickly admitted to HDU, and you've got the gastro team and the surgeon saying,
human being in the gap.
Yes, yeah. So So only 3 days. Well, I say 3 days. So 3 days, but yeah, exactly. It took 3 days to get all the imaging done and then to come to the diagnosis. Thank you.
Thank you, Dr. Zeeshan, for this really interesting case, and I would also like to extend my thanks to our other presenters for bringing these really, really interesting cases for oral presentations here at our 5th annual RF conference. Also, special thanks to our moderators, Dr. Memon, Dr. Shazad, as well as Dr. Rahman Ahmed and Dr. Rashid here with us in person. A big thanks to my fellow moderators, Dr. Dhaliwal and Dr. Ghias. This presentation concludes session 4 of this stream. We will now have a 30-minute break, and we will be back around 2:50 UK time for session 5. Thank you.